Okay, good morning, everybody. I want to thank you for joining us today. I want to thank the UCLA Alumni Group and all the Bruins online. I see there's 200 of you at this point. I'm very excited to give you this talk today. My name is Omai Garner. I'm an associate clinical professor here at UCLA in the Department of Pathology and Laboratory Medicine, and I am section chief of our clinical microbiology laboratory. My laboratory performs all of the COVID-19 testing for the UCLA Health System, and today's talk is about testing strategies to help manage the COVID-19 pandemic. You know, I really want to sort of pull back the veil on COVID-19 testing, talk about the different types of tests that are out there, what those tests are good for, the PCR test, the serology test, the rapid tests, sort of talk about how they work, why sometimes they take a long time, and really answer any of your questions centered around testing. Again, the reminder for questions, they should go into the Q&A and we will address them at the end. So again, thank you for joining us today. Okay, so some objectives for this particular talk. I hope that you'll be able to identify current COVID-19 testing status and what might be next for laboratories in the United States, define and help to understand fine-tuning of COVID-19 diagnostic algorithms for both molecular testing but also serological testing, and then discuss current testing recommendations and their implementation by one clinical laboratory. My laboratory is representative of the laboratories across the country working very hard to be able to provide COVID-19 testing to help battle this pandemic. To introduce the group to the UCLA Health System, so our health system has two hospitals, the Ronald Reagan Hospital, which is about a 500-bed hospital that really primarily serves the very, very sick in our community, Santa Monica Hospital, which is around 300 beds, I think a couple of miles away, and then we have about 225 outpatient care clinics where we service patients. We have one centralized clinical microbiology laboratory. What this laboratory does is all of the infectious disease diagnostic testing for the health system. So I have two faculty members that assist me, Dr. Suki Chandrasekaran on the left and Dr. Sean Yang. The laboratory does close to 1.5 million infectious disease diagnostic tests per year. And we have about 120 staff members that work hard in the building. We have all of the various areas of infectious disease testing, including bacteriology, virology, take most sample types from people, and we're really assisting in the diagnosis of infectious disease. So our tests for things like pneumonia, sepsis, upper respiratory tract infection, we do all of the STD testing for the health system. And if you look very specifically at my virology lab, which is really the focus today, right? COVID-19, SARS-CoV-2 is a virus. And so in that setting, we have a lot of qualitative PCRs. These are PCRs that really just give you a yes or no, is the pathogen there, kind of like flu testing. So we do that for a wide variety of viruses. We also offer a limited amount of quantitative PCR testing. This is, let's say, a patient needs to know exactly how much HIV is in the blood, exactly how much CMV in the blood. In that, we're able to give an exact number in that setting. So for COVID-19 testing, we have really two patient testing algorithms. We have a 4 to 6 hour turnaround time result for our inpatients and a less than 24-hour turnaround time result for our outpatients. This is key. You know, I think a lot of you have heard these stories across the country where unfortunately people are waiting 7 to 14 days to get a PCR result. One of our priorities at UCLA was to really provide a result within 24 hours at the maximum amount of time, and for the inpatient setting, for the very severely sick, try and get a patient result back for COVID-19 within 4 to 6 hours. So I want to talk about how we did that, but I really want to talk about this pandemic as a whole, so you can see how testing then fits into that. So a brief history in California, February 26th, which gosh, now is only 8 months ago, but feels like 8 years ago, UC Davis reported their first patient with community-acquired COVID-19. This means that the patient didn't travel to a country where we knew a COVID-19 outbreak was taking place and that had to have acquired the infection within the community. It really was what we think is the start of the COVID-19 community-acquired pandemic in California. By March 13th, so a couple of weeks later, we had our first patient with COVID-19 diagnosed at UCLA. 4 days later, we closed the hospital to outside visitors, really trying to get a hold of this pandemic and keep it outside of our hospital system to not interact with the sick patients we already had in the hospital. And then if you'll all remember, 2 days later, we of course had the California stay-at-home order. So some of the challenges that were really represented in that first week of this pandemic, rationing tests, right? The lab, as I had it set up at that time, wasn't able to do very many tests. We were one of the first hospitals in Southern California that had a COVID-19 PCR test, but I could really only run about 60 tests a day. You'll learn today why that was. And there were some questions on false negatives, right? If somebody had a negative on this test, did they really not have COVID-19? This was tied into how we were going to handle our patients. Did patients need droplet isolation, meaning how you kept patients away from each other with COVID-19 to stop infections from moving around in the hospital? There was a lot of controversy early on about treatment and treatment recommendations. And then, of course, the reports were coming out of New York at that time about extreme PPE or personal protective equipment shortages and extreme ventilator shortages. So being able to treat patients appropriately. If we all remember, this was a very fearful time, justifiably so. So COVID-19. COVID-19 is an acronym. And so the COVID stands for Coronavirus Disease 2019. Now, the syndrome or the disease is named COVID-19. The actual virus that causes disease is called SARS-CoV-2. And we're going to get into why it was called that. If you look at this overall picture of exposure and infection, what appears to happen, and again, it took a while for this data to come out. I want you to appreciate we're only 10 months into a brand new infection. So the science is learning, the science is changing. But what we know up to date at this point is that sometime within 0 to 14 days of contracting the infection, a patient can move to the onset of symptoms. Now, we know not everybody who gets exposed moves to the onset of symptoms. But for those people that do, that early period is called the incubation period. Somewhere within this 2-day window is really a pre-symptomatic period where the virus load starts to go up as people approach the onset of symptoms. Now, at the onset of symptoms, of course, symptoms are fever, cough, fatigue, anorexia, myalgias, potentially diarrhea. And there's a wide variety of those symptoms. It can be very, very mild all the way to very, very severe and requiring hospitalization. But what we've seen is that really there's a 7-day window of symptoms before patients move to dyspnea or trouble breathing, and this is in 40% of symptomatic patients, and 10 days before they move to potential critical illness. Now, of course, that critical illness also goes in line with known comorbidities, and then unfortunately is overrepresented from a critical illness perspective in underserved communities. Okay, so let's talk about viral pneumonia. So when we think about viruses that cause pneumonia, and pneumonia is lower respiratory tract infection. So dividing the two up, a cold virus or a runny nose, something like a cough, things we've all experienced, that's an upper respiratory tract infection. It really doesn't involve infection in the lower lung. But if that infection moves down to the lower lung, it can be very, very severe, and pneumonia can even be life-threatening. So in that setting, we don't typically think of viruses that do this. The main viruses that we know that cause lower respiratory tract infection or pneumonia, of course, is influenza. Influenza is classic for this. And then another virus called RSV, respiratory syncytial virus, and this mainly affects children under 5 and the very, very elderly. There are a lot of other viruses out there that can cause upper respiratory tract infection, but they don't mainly cause pneumonia unless a patient is severely immune compromised. So potentially severely diabetic, potentially has AIDS, post-transplant, all of these things that suppress the immune system can cause a virus that only typically causes upper respiratory tract infection to actually cause pneumonia. And as you can see here, the list is very long. What I highlight for this, and this is what we're really going to talk about with COVID-19 to begin, is that coronaviruses are on this list. We know about a group of viruses that COVID-19 is a part of that can cause pneumonia. So let's talk about coronaviruses. I'm a microbiologist. We had to have some microbiology pictures in this. So coronaviruses, these are electron micrographs of these viruses. They're enveloped, non-segmented single-stranded positive sense RNA viruses. And they're named corona because you can see these projections along the outside that almost look like spikes on a crown. And so that's what they're named after. What's interesting is these projections are the spike protein. And the spike protein itself on the coronavirus allows that virus to infect another cell. Now, these have been recognized as animal pathogens since the 30s. So we've always known coronaviruses have been there, but human coronaviruses weren't recognized until the 60s. Studies in animals show that coronaviruses usually cause respiratory tract infections in animals and sometimes lower tract either pneumonia or GI symptom infections. Human coronaviruses, we know, almost exclusively just cause respiratory tract infections. Here's a table of our known human coronaviruses. So not COVID-19, not SARS. These are 4 globally circulating coronaviruses, OC43, 229E. Their name isn't as important, but what you can see here under the disease category, they mainly cause upper respiratory type infection. In fact, the human coronaviruses are one of the more common causes of the common cold. So we've all had these viruses. If you've had a common cold during the winter time, they're usually seasonal and they can cause mild disease. Now, what's interesting about all of the coronaviruses, and here's where I kind of want to demystify how COVID-19 came about. All coronaviruses are caused by a spillover event. And so a spillover is this concept where a pathogen moves from one species into another. It's called a zoonotic infection. A lot of pathogens that infect human beings are actually from animals. They're caused by spillover events. And I want to give a shout out to one of my favorite books by David Quammen called Spillover, and it really represents in a very reader-friendly, story-like way some of the infections that we know about that are spillover events. Either Hendra, malaria, influenza, pandemic flu is also a spillover event. So in looking at the coronaviruses specifically, and here you see some of the first 4 coronaviruses, the ones that cause a cold, we have identified through research the original animal that these viruses came from. So if you look at 229E, it appears 229E started in bats, and a lot of coronaviruses appear to start in bats. Were transmitted to a llama, and you'll see the transmission as these viruses jump around before they get to human beings are usually spread through domestic animals because we have so much contact with domestic animals, and then move on to the human being. Same thing here with human coronavirus OC43, started in a rat, spread to domestic cattle, spread to human beings. And so this notion that a virus can move from an animal like a bat to another animal to a human is actually not unusual. In fact, I would tell you that that is the norm for these coronaviruses. And so COVID-19 taking this pathway, also not unusual. That said, spillover events are common, right? Anytime a person comes into contact with an animal, they can potentially catch disease from that animal. I know a lot of us out there are pet owners, whether you have a cat or a dog, and you feel like you can't catch disease from those animals. You absolutely can. So there are viruses, there are bacteria that can spill over between these species. Now that's common. How does it then become a global pandemic? So in looking at this, we have a virus, and that virus has to have a high host plasticity. What that means is that virus can actually infect a large number of different species. Usually that's because the receptor that virus uses to infect is found in those species. So with COVID-19, we have a virus that starts in a bat with coronaviruses, and it can infect more than just a bat species. So a different species is infected, or maybe the bat directly interacts with a human being, and you have a human being that gets the virus. Now, if it just stops there, that's it. It does not become a pandemic. But if that virus is actually able to transmit between people, we call this human-to-human transmission, now you have something that could cause global spread, right? We all know that at least before this time, you could get on a plane and be halfway around the world. Upper respiratory tract infections are so easy to pass, sneezing, coughing in your hands. And this was actually the route for all 4 of the known human coronaviruses. When a cold virus makes its way around the world, nobody notices. But when COVID-19 makes its way around the world, unfortunately, this is what happens. And this is where we are today. So again, to demystify, COVID-19 isn't that unusual in its movement from animal to human species or in its movement between humans. It's just unfortunate that COVID-19 has a much higher morbidity, which is a word we use when people become sick and severely sick, and mortality, which is a word, of course, we use when people die. So in tracking this pandemic, this is my favorite website. It's from Johns Hopkins, and you can see here the global numbers as of Friday. When I pulled this data, we have 39 million people infected worldwide and 1 million global deaths. And if we move on, of course, you can see that the United States is one of the hardest hit countries. And our county, right, for Los Angeles, we unfortunately lead the way with the highest number of cases, 287,000 cases. Now, I'll also say we have one of the largest counties in the United States. We have 10 million people in our county. Our county is larger than some states. That said, you can see the overall numbers. And so COVID-19 is a coronavirus, as now a coronavirus spreading disease in human beings is very, very serious. So with that background in the microbiology of disease, I want to then expand out to understand testing, why testing has been so slow and what that means specifically, and then start to analyze the different types of tests that are available and understand exactly what it is that they mean. Okay, so sometime in late December, right, whether it was December 31st, a couple of weeks earlier than that, there were a cluster of pneumonia cases found in mainland China. What was interesting about that cluster of cases is that all the known diagnostics that are out there, diagnostics that are similar to my laboratory, were not able to identify the pathogen. Tricky thing, this is flu season. So the first guess was probably these patients had flu, but they were all flu negative. In fact, they were negative by PCR for a large number of diseases. This is what led the Chinese CDC to think that potentially there was a novel virus at play. Now, they had experience with this. If you'll remember the SARS-CoV-2 outbreak, that outbreak in the early 2000s also started in that area. So there was an idea that there may be a novel coronavirus. Relatively quickly, like within 2 weeks, and this is really a triumph of molecular diagnostics, they were able to identify and have a full genome of this virus by 2010. I mean, by January 10th, 2020. They found out it was a novel coronavirus, so a new coronavirus species that was closely related to SARS. So SARS is the severe acute respiratory syndrome coronavirus. So closely related, in fact, that they named it SARS-CoV-2. Now, it was initially thought that all of the infections were related to one seafood market that really represented not as unusual a market space as you see in many areas of around the world, but a market space where animal spillover to the human population was very possible, right? You had wild animals mixing with domestic animals, mixing with people, creating an environment for spillover. Again, I emphasize these markets exist globally, but they do create that particular environment, and it appeared most of the cases were related to that particular market, but it relatively quickly became apparent that human-to-human transmission was occurring. So how do we deal with this at UCLA, right? Since my tenure being here, we've had to tackle measles crises from Disneyland, the Zika virus crisis, the Ebola crisis. So we were relatively well versed on how to at least initially think about a pandemic. So we started to create a system where people under investigation, or PUIs, who would show up at UCLA Health would be screened to see whether or not they potentially had COVID-19. So the screening would, of course, include travel history, symptoms of cough, shortness of breath, or fever. And we are one of the main travel hospitals for LAX. So if somebody shows up to LAX and they're sick, they come to UCLA Health. So in that setting, we were receiving patients at this time that potentially had COVID-19. The challenge was we did not have a test. So why didn't we have a test in my lab at this point? Well, the federal government was not allowing hospital laboratories to do testing at this time. In fact, the only test that was available across the entire country was at the CDC. Now, as you all know, the CDC is in Atlanta, and Atlanta is nowhere near Los Angeles. And so we would have to collect specimens from that patient who we had in isolation at UCLA, send those specimens all the way to Atlanta to be tested for COVID-19, and then the result had to come back. Average turnaround time was about 5 to 6 days. as the infection was spreading around the country, more and more people were persons under investigation. More and more test results had to go to Atlanta to be tested, and they quickly became overwhelmed. The turnaround time started to extend and extend and extend. So they put out a strategy of moving the CDC tests for COVID-19 PCR tests to the public health laboratories, using the public health infrastructure to be able to do the testing. Now, this also isn't unusual. In the Ebola outbreak, I didn't perform Ebola PCR testing in our laboratory. We sent it to public health. The challenge with the Ebola outbreak was that there were only 1 or 2 patients. The challenge with COVID-19, as we are now well aware now, is that thousands, tens of thousands, hundreds of thousands of people need to be tested. So they moved the test to our local LA County Public Health Lab. A shout out to that lab. We have one of the highest quality public health microbiology laboratories in the entire country. They service the 10 million people across LA County, and they tried to bring up this test. There were some mistakes that were nationally publicized about how the test was put together from the CDC, but eventually they got the test up and running. The challenge when they did that is now there were far too many requests for them to be able to meet the need. So UCLA was sending to Downey, which is where the public health laboratory is, tests, getting the results back. And initially that was 24 hours, but then it started to extend longer and longer and longer as more and more tests needed to be performed. Still at this point, the federal government had not allowed hospital laboratories like mine to actually perform PCR testing for COVID-19. That all changed February 29th. So the federal government realized that they were going to need to allow hospital labs to do this. I would argue that they were far behind in that realization, but at that point, they took the handcuffs off and allowed laboratories like mine to do testing, but it was very, very limited the types of labs that could do testing. So what they said was you could perform the CDC test specifically. Now, the CDC test, interestingly, and I'm going to introduce that test to you, requires specialized equipment that's not available in most clinical labs, highly trained molecular microbiologists that are also not available in a lot of hospitals. So most clinical labs couldn't bring up the test. We were fortunate at UCLA to be able to do this, but most hospitals across Southern California couldn't even bring up this test. There was a separate pathway where you could develop your own test, but that also was very, very difficult. So most labs couldn't run it. So let's talk about the test itself and then work our way through the process so that I can give you some more details of the PCR test. So what happens when a coronavirus test or a COVID-19 test is performed is initially there's sample collection. Sample collection is this really, really deep nasopharyngeal swab that you can call here. Now this is happening at what people are calling testing sites. Unfortunately, these are not testing sites. These are just collection sites, right? These are like in LA County, Dodger Stadium. There's no testing being performed at Dodger Stadium. There's just sample collection. Then once it's collected, it needs to travel to a centralized laboratory, a laboratory like mine for testing. Now, you know, if you're within a certain square mile of my laboratory, you can get that result there very quickly and we can perform testing. You can get that sample there. But let's say you live in a state where there aren't centralized testing facilities. Then in that setting, if it's collected, it may take 3 or 4 days to actually even travel to the laboratory to be performed. This is why you're seeing 7 to 14 day turnaround times for PCR testing, because the testing does not happen on site. Once it gets to the laboratory, then it gets in the queue for testing. So once it arrives in my laboratory, we have all of the tests that arrive within a day out within 24 hours. But that's going to be dependent on the queue at that lab. If a lab can perform 1,000 tests a day, but there are 5,000 specimens waiting to be tested, that lab is already 5 days behind in performing testing. So again, if it took 4 days to get to the lab and an additional 5 days to get through the queue, the turnaround time is now 9 days. So you can see the problem across the country for testing isn't necessarily the test or the collection. It's getting it to the centralized lab and having the centralized lab have enough throughput to be able to perform that testing. Once it hits the lab, we run something called DNA-RNA extraction, getting all of the nucleic acid out of this original sample. And then we run an assay called RT-PCR that looks for the presence of viral RNA in that, and it's exquisitely sensitive at doing that. Here's a picture of the virus, so you can see kind of the corona drawn out. There's the spike protein, and we have multiple gene targets that we're able to use by PCR to be able to target this particular virus to know whether or not it's there. So to walk you through some of the assays that are performed, the first test we brought on, because remember, it was the only test that was available, highly specialized equipment, was the CDC test. The CDC COVID-19 RT-PCR test has a couple of gene targets on the nucleocapsid gene. If both targets are positive, it's a positive result. If one of two targets are positive, it's again conclusive, and we'll talk a little bit later about what that means. If both targets are negative, it's a negative result. Now, the challenge with this particular test, so as we discussed before, everybody was a bit behind in the testing because so much volume needed to be done. This test was not built for volume. So if you look at the test itself, it requires about 2 hours of extraction. And then on a 96 well plate, you need 3 wells per patient. And so in that setting, I can only really do 30 patients per individual plate. And the whole process takes about 6 to 8 hours. Well, if I can only run 30 patients in 8 hours, and I can do that maybe twice or 3 times during an entire 24-hour period, now suddenly my laboratory is hamstrung, right? I can only do 60 or 90 tests total because this is the test that we were all being forced to use. And so it came out as an accurate and yet very, very low volume test. So you're starting to see why, again, we were so far behind, and we still continue to try and catch up. So we brought this test on for patient care while we kept looking for more tests to become available that were faster. As we moved into March, more diagnostic manufacturers will be able to get tests through the FDA and get EUA approval. And so we brought on a second test, the Diasorn molecular simplexa test. Now, what's interesting about this test is that it requires, again, a couple of different targets on the gene, but it's only an hour and a half to run the test. And so as opposed to the 8 hours it took the other test to perform, and we were getting, from a reagent perspective, the ability to do about 300 tests a day. So in that setting, suddenly I've moved from being able to do 60 to 90 to being able to do 300, and at 300 I could turn around much faster. So this was the test we moved forward with for inpatient testing. We knew our patients that showed up to the ED and our patients that showed up inpatient needed to have a result within 4 to 6 hours. And so here you can see our overall turnaround time, and we keep that below 4 hours for patients in those 2 settings. But still, I'm only at about 400 tests a day. 400 tests a day is still not enough PCR tests to cover all of the testing we need to perform at UCLA Health. So I was looking for more testing. As of then late March, early April, we were able to bring on a truly high throughput test. This is called the Thermo Fisher TaqPath test. This test also multiple targets to be able to call a positive. What's interesting though is that I could run up to 1,000 tests per day on this. Very similar to the very low volume CDC test, but instead of being able to only run 30 specimens per plate, now I could run 90 specimens per plate. And so we brought in a large number of these because they were available, and we were able to push out about 1,000 tests per day. The challenge is it's not as quick. And so in that setting, when you look at our turnaround times, and we're using this for outpatient medicine, for our turnaround times, we wanted to keep them below 24 hours. The reason there is that makes it actionable from a clinician perspective to have that result within 24 hours. And you can see on average, we're around 15 hours turnaround time from when the specimen is collected to when the result is back to the clinician. But I think this just represents the challenge that we were facing. I don't have multiple testing platforms for one disease. In fact, it's important not to do that, because what if there's variability in the accuracy of those testing platforms? So because there's been such a shortage of tests, and because some of the tests are too slow, it really has driven clinical labs to go outside of what they normally do. I now have 5 different PCR tests to be able to do COVID-19 testing, all because it meets the need for our patient population at UCLA Health. So, a natural first question is, well, are all your tests the same, right? Are all your tests equivalent accuracy? And we looked at that, right? It's important to be able to look at that. They all had different gene targets. They all ran on slightly different systems, even though they were all PCR. So we made a comparison across those 3 tests that I told you about, looking at our overall positivity rates, our overall rates of inconclusive and invalid results, and then generally how strong the signal was. You can get this semi-quantitative reading of how much virus is there, potentially looking at something called a CT value. And as we looked across the 3 tests over about 10,000 different results, we were confident that all 3 of our tests were performing the same. So whether or not a patient came in to our inpatient setting, our ED setting, or our outpatient setting, they were getting the equivalent high quality PCR result, which is the gold standard for COVID-19 testing. But there were questions that still needed to be addressed. So one of those questions was, is the test sensitive? Meaning, how likely is it that this test produces a false negative? Very much a concern. It's a concern for all the tests that we run. We divide the understanding of that up with this concept of analytic sensitivity. And this is how high quality is the test itself for finding the virus. The way that we measure this is we actually spike individual virus into specimen and see what we recover it at. And what it showed is we can get down to about 100 copies of virus per mil. This is exquisitely sensitive. So what I told our clinicians is, if the virus is in the sample, we'll find it. But really, a false negative result asks a broader question of, is the virus in the sample? Lots of things go into that. Proper specimen collection, right? If you did that really deep nasopharyngeal swab versus a throat swab, what are the sensitivities between those two? How likely are you to find the virus in one versus the other? And then how does the virus move around for the disease? When somebody's asymptomatic, do they have a very low amount of virus? As they're approaching symptoms, does the virus climb higher? What about somebody who has very, very severe disease? Is the virus still efficiently found in the areas that you're looking for it? And so we had all these rumors coming about, well, I hear your PCR test only has a 63% sensitivity. That means out of 100 positives, you only find 63 of them, and the other 37 are false negatives. So in order to address this as a laboratory, because again, we were concerned about this as well, we looked at repeat testing across our population. And so we call the false negative somebody that has a nasopharyngeal swab PCR that's negative, and then any time later has a positive, versus somebody that has an initial negative and then repeat testing, they continue to be negative even if their symptoms change. And what we found is that our clinical sensitivity or accuracy in that setting is about 98%. So there were really only 2% of the time where somebody had an initial negative that ended up converting to positive at some point. That initial negative could have been a spore specimen. That initial negative, they could have been too early in disease. But it gave us the confidence that a negative result on a nasopharyngeal swab is a trustworthy result up to 98% of the time, which is equivalent to a lot of the other tests that I run in my laboratory. No laboratory test is perfect. And we're here to support the clinical work that's being done by our physicians. But in that setting, this showed we do have a good assay. RT-PCR is a good assay. And even across multiple testing types of RT-PCRs, the numbers came out the same. The next question that came up around PCR is which specimen type is the most sensitive? You know, there was some data that showed that lower respiratory tract specimens, things from lower lung may be better for severe disease. And some of our data showed that. So if you look at bronchoalveolar lavage, this is a wash in the lower lung. If you test that on our patients, we had about a 7% positivity. But if you just test nasopharyngeal swabs, we had about a 3.2% positivity. But looking at those individual patients, everybody who got a BAL also got a nasopharyngeal, and the nasopharyngeal was always positive when the BAL was positive. So it showed us that both had a good sensitivity in severe disease. Another thing I want to briefly talk about are these inconclusive or indeterminate results. What does that mean when you get them back? So we looked into subsequent testing of those patients, and what we found is that sometimes it represents a weak positive, and sometimes it represents a false positive. And really the only way to work that out is by repeat testing. So of course our suggestion then is if somebody gets an inconclusive result, they get a recollection and they're repeat tested. So then if you look at the spectrum of our RT-PCR tests, we've done almost 100,000 patient tests. So far, we've done well over 100,000 tests. And what you can see here, our total positivity at UCLA, we've had about 3,000 positive test results. Our current hospitalization rates are very low. We only have 5 people hospitalized with COVID-19. And here you can track how the testing was going as per how we were doing as a community, right? If you remember that spike in COVID-19 cases in July, you can see a spike in the number of tests that we were performing as well. So in my last 10 minutes, I want to pivot away from the PCR test and over into antigen testing and serology testing. Antigen testing is very controversial. So this is testing that happens usually outside of a centralized laboratory. You can see there have been some very famous failings in antigen testing. Nevada recently had to halt the use of rapid coronavirus testing in nursing homes because of too many false positives. The White House did a lot of either point of care molecular or point of care antigen testing, and this was not as a plan in and of itself, not combined with masking, able to discover everyone who was infected. And it's good to ask why in these tests. So this is the structure of an antigen test. It's very similar to a pregnancy test, something we're familiar with and taking it home. An analyte goes onto a horizontal specimen or a lateral specimen. And that analyte could be a swab, could be saliva. You imagine there's some kind of virus in there, and as it moves across the specimen, it picks up antibodies. Those antibodies then will bind to a test line, and that sandwiched antibody antigen line will give you a positive result. And if you read a pregnancy test, you see the line or some kind of symbol that tells you whether it's positive. The challenge of these tests is they have an inherent lack of sensitivity. It takes a lot of antibody-antigen interactions to produce an actual signal. So when you compare them to PCR, you know, they're somewhere between 500 to 1,000 times less sensitive than PCR. So what that means is that you need 500 to 1,000 times more virus in a specimen for it to be antigen test positive versus being positive by the PCR. There are quite a few of these on the market now. So the Abbott Binax now is very popular. This is the one the federal government has a lot of. This works very similar to a pregnancy test. So you can see the sample line and the control line would need to be positive. And then we have similar tests that are done by a reader. So what's the advantage? Quick turnaround time, 5 to 15 minutes. Remember that whole system I set up of collection, moving to a lab, waiting in the lab line, all of that is gone. The disadvantage, though, is there's this real lack of sensitivity. They only work when the viral load is at its absolute highest. So what does that mean? That means they're only recommended for use in the first 3 to 5 days of symptomatic illness. If you use that time, that's when the viral load is the highest. That means they'll have a good, reasonable accuracy to PCR, up to 90%. They'll catch 9 out of 10 PCR positive specimens. And that's where all of the data around these tests occur. If you hear about these tests, if you hear these companies talking about these tests, they're going to talk about that particular window specifically. The challenge is outside of that window, it doesn't work much well at all. There's a large-scale study on this that came from the Cochrane Review that looked at large antigen testing populations and studies, and what it showed is that antigen tests have an average sensitivity of about 50% compared to RT-PCR. This was about 940 samples, none of them done on these current platforms because these haven't been available for study, unfortunately. But in that setting, it just sort of repeats what we think about. So how do I put that then back into our symptom purview? Here, COVID-19 antigen testing, very good in this sort of onset of symptoms to maybe out to 7-day window, but really no data outside of that. And any tests that have been done outside of that, you see false negatives in this setting, and also importantly, because again, there's been a suggestion that antigen tests should be used in the asymptomatic screening population. False negatives can occur in that setting as well, whereas molecular RT-PCR testing can cover a much broader range. Finally, I know we're packing in a lot of information here, but I want to be able to tell you as much as I possibly could about all of these different types of tests. Let's talk about serology. Serology is this measurement of antibodies that are made in response to disease. So it's your body's immune system fighting disease. So what does this look like? So a pathogen gets inside the body. It's picked up by macrophages, which are these cells that circulate around the body looking for foreign things. And then those macrophages present that infection to your T cells and B cells. Your B cells then make antibodies specific to that infection, and that's what we measure. So if we're measuring IgG and IgM, we're measuring those antibodies as related to this antigen. Now, this takes time, right? So serology testing is not good for early infection, and understanding how much time this takes allows for our ability to understand when serology should be used. Okay, so right now, it's unclear if you're serology positive, meaning you have COVID-19 antibodies, if you're protected, or if those antibodies actually directly fight the virus. Until we figure that out, we can't really tell anyone who's serology positive whether or not they can be reinfected. And this is important because you would think maybe a behavior change could come about if you have COVID-19 IgG, but that is not suggested at this point. If you look at the median seroconversion time, seroconversion is the idea how long does it take for a person to make antibodies. The guess is it's out to 21 to 28 days on average that a person who had COVID-19 will then have antibodies. So we do some of this testing at UCLA in my laboratory. The accuracy is pretty good, so it's pretty sensitive for people who have had COVID-19. They'll have some level of IgG. The target protein for the antibody is antibodies that are made to the spike protein, and we run this on a high volume platform that has good reliability. But there's a big caveat to this. And this caveat is about positive predictive value as related to prevalence of disease. And this is something we think about in lab medicine a lot. The concept says the less prevalent a disease is in a society, the more likely that a positive test result may be a false positive. Whereas the more prevalent a disease is, the less likely a positive test result. So the rarer the result, the rarer the positive result, the more likely that's potentially false positive. This is shown in this table here. So if you take the sensitivities and specificity, so the idea that it doesn't have false negatives and doesn't have false positives, and you put that into this table, you can see that if you have a prevalence of 20%, meaning 20% of the tested population has COVID-19, then in that setting, your positive predictive value is 96%, meaning if you get a positive result, you can trust it. But if the prevalence is as low as 1%, and I'll argue out in our society, for people who are asymptomatic, that's probably about likely true for COVID-19, the positive predictive value drops down to 50%. So even if you get a positive test result, if you don't fit into one of these prevalence categories that's a little bit higher, you actually can't trust that test result. So how do we put all this together then in a set of recommendations for what we should do for serology testing at this point? So here are our recommendations at UCLA Health. COVID-19 serologic testing, or testing for IgG, should be considered for the following situations. Suspected of prior infection that was not tested by PCR. Remember, there was very little PCR to begin with. March, April, I'll even argue May. It was difficult to get a PCR test. So potentially if somebody had symptoms at that time and they didn't get tested, we move them into a higher prevalence category, right? They were symptomatic during a time when the infection was here. Those are appropriate to test by serology for IgG. Now, it doesn't necessarily say anything about them being protected, so it's more of a curiosity than actually something you can act on medically, but at least it doesn't fall into that same problem of positive predictive value. Healthcare worker or first responders, same thing. Higher prevalence, higher exposure rate, you can trust the result. Plasma donation for convalescent plasma is actually critical, potentially, to know someone's IgG result to see whether or not their plasma can be used. And this test is performed at a tighter level for that donation. And then potentially in the setting of convalescent patients with a history of COVID-19-like illness, where the PCR is negative but the clinical suspicion is high. That's really where serology testing exists right now. I think the true value for serologic testing is going to be vaccine efficiency. So once somebody gets a vaccine, you need to be able to have a measure of the antibodies that are there to prove that they're protected, and then you'll see serology testing used much more widespread. It should not be used when trying to diagnose acute COVID-19. It's from that picture I showed you early on. It takes time for the immune system to recognize a pathogen is there. So if somebody is symptomatic, serology testing is not appropriate to be able to diagnose them. And if somebody's asymptomatic, let's say you're having a party and you want to test everybody coming into your party, and we've seen this by running COVID-19 serology testing, that doesn't tell you anything about whether or not they're in that pre-symptomatic window where they could have enough virus to be contagious, but not necessarily be symptomatic. And then finally, we shouldn't be testing low-risk community members because you fall into that low prevalence category and you can't trust the positive result. So how do we get out of this, right? Testing is not our way out of this. Testing supports this, but really the data is very strong. Masking is our way out of this. We need to slow down the overall amount of infection that's out there, especially as we approach flu season, as we approach potentially a third spike in the overall amount of COVID-19. We just need more widespread masking. And then, of course, vaccines, right? We're really banking on some of these vaccine candidates to be efficacious and safe to be able to bring down the overall amount of infections. So that was my last slide. It's how we're going to fight COVID-19. I want to thank you for your time. We've left time for questions. I want to thank all 315 of you for being here. This is really amazing. And the laboratory is usually not up front, but as you can see, you know, my laboratory has had some articles in the LA Times talking about the work that we're doing. And for you 300 that are on this, I want to leave you with a picture of my virology laboratory. These are the people that have been doing the COVID-19 PCR testing. My lab techs have been working overtime. They've been working on the weekends. They've really, as frontline, been putting everything they can into fighting this pandemic. And I really just want to thank them all for all of their effort. And we will transition to some of the questions. So I have 13 questions that are open right now. I have 13 minutes. So we're gonna move through this relatively quickly. Okay, so the first question, isn't regular rapid testing the only way to go in order to deal with COVID fatigue and the denial of people possibly being asymptomatically infectious? You know, I think that that is a great question, and I would say we don't know the answer to that specifically. So it is one way that you could imagine using antigen testing, and that's been tried. But remember, antigen testing hasn't been proven to work outside of that symptomatic window. So the danger then in doing that is that you're going to miss infections. And the other challenge with antigen testing is that there have been some known false positives, and the detriment from those false positives can be high. So I think that it's an interesting theory. There aren't enough manufactured antigen tests to actually fill that as a theory, but I think we need to be creative, right? There aren't going to be enough PCR tests for everybody, so we have to work as best as we can to be able to use the tests that are available. They just need to be used in the right settings. What percentage of your tests are meeting your maximum 24-hour standard? The answer to that is fortunately 100% of our tests come back in less than 24 hours. We work very, very hard for this. Is there any COVID testing that can provide quantitative results of viral load? I would love for that to be true, but right now the answer is no. So when you look at PCR testing, PCR has the ability to do viral load testing if you have quantitative standards. We do not have quantitative standards with this test. The other challenge of viral load testing is that it's not done in respiratory specimens because respiratory specimens are dirty. And by dirty, I mean that they're not homogeneous in the amount of material that they have. So I can stick a swab up somebody's nose and come away with a lot of snot. And I can stick a swab up somebody's nose literally a minute later and come away with just a little bit of snot. And if you compare the viral loads between those two, there will be drastic differences. So again, the specimen itself does not speak well for doing viral loads, which is why we don't have quantitative PCR tests for things like flu. So I don't think there will be quantitative PCR tests that are out there that will be used. We do some relative usage in the inpatient setting, but it won't be used across the board for good reason. The next test says, please go over the level of viral inoculum and symptoms. That's also a great question. So it appears that if somebody's going to move into the symptomatic window, during the pre-symptomatic window, a day or two before they become symptomatic, the viral load starts to increase. And people can actually be PCR positive in this pre-symptomatic window. This is the reason why we're all wearing masks, is because there can be viral transmission in that pre-symptomatic or asymptomatic window. The virus peaks usually the first few days of symptoms or right around when symptoms onset starts and then goes down from there. So people are highly contagious once they're symptomatic and potentially highly contagious in that region right before they're symptomatic. The true asymptomatic person that never approaches symptoms, we don't know a whole lot about. Those people are hard to study because we don't really have enough testing to go out and find those people to be able to know how much virus they end up having. So the next question is, have there been mutations of COVID-19? Another great question. So yes, there have been mutations of COVID-19. RNA viruses mutate. They don't have the machinery to be able to make consistent viral products over time without mutations. Some of them mutate very fast, HIV, influenza. Some of them mutate on a much slower basis. Fortunately, coronavirus actually mutates more slowly. So in that setting, while we're always watching it, so we can do something called viral whole genome sequencing to figure out how fast it's mutating, and we do this at UCLA, we're watching to make sure, let's say, the mutations don't affect where the PCR targets. So we would start to get false negatives. But we have not seen mutations that have affected that generally, or mutations that have affected the virus to make it, let's say, more contagious, or to make it cause more severe disease, and we don't expect that to happen. Mutations can also play a little bit of havoc with vaccines, but all of these are concerns that are being watched. I would just say we are in the fortunate scenario for coronavirus that while it does mutate, it does not appear to mutate that quickly. Next question, after sample collection, how long can it be accurate before actually tested in case of a backlog? So we do specimen stability studies to answer that question. So how long can you hold it at room temperature? How long can you hold it refrigerated? How long can you hold it frozen? And we work our best to meet those sample storage times. Now, what's nice about this virus is it's actually very stable frozen. A frozen specimen can actually be stable for testing for months. And so as long as the specimens are being frozen, those specimens that are moving 7 days, 14 days to be tested, again, not good, not clinically a good turnaround time from a result perspective. The result will still be accurate after it comes back. The next question says, how long after infection will the antibody test still show positivity? This is a controversial question, and I don't know the answer to that. So we have seen in certain antibody tests, they'll wane over time. Whether this is connected to whether or not a person is protected is still trying to be worked out. And so I would just say on that question, it's the right question. It's the question we're asking right now, and it's something that we need to figure out. Next question. Based on your evaluation of collection method, can you say whether a sample collected with a simple shorter nasal swab is less accurate than one collected with a longer nasopharyngeal swab? I would say that in the case of somebody who is having symptomatic illness and you collect when the viral load is at its highest, it doesn't matter. So there are some good studies to suggest that a mid-turbinate swab, which is one not as quite as so far back as the deep nasopharyngeal swab, the results from an accuracy perspective are almost the same. Outside of that window, we have seen some extreme variability. So outside of that window, let's say in the asymptomatic testing population, or the population where you're really trying to find a low amount of virus that's there, the specimen collection does matter. And the nasopharyngeal specimen is the best specimen. Now, I will say other specimens like throat or saliva, the data is still being collected, and there's a lot of conflicting studies as to whether or not those samples provide a high enough sensitivity. At UCLA, our opinion is we should use the nasopharyngeal swab for somebody who is clinically trying to be tested. And potentially there are some scenarios where the mid-terminate swab is appropriate, but we have not moved to saliva or throat or any of the other ones. Next question. Any type of testing that you recommend for teachers and students returning to school, surveillance testing recommended or not? This is another question I do not know the answer to. So these are things that are being considered right now. You know, I would say in the best possible scenario, and this is hypothetical, and also there aren't available tests to do this. If you wanted to ensure safety, you would run a nasopharyngeal PCR test on everybody every day, regardless of symptoms. Now that's myth. We don't have nearly the number of tests to be able to do that. So then backing off of that, if that's going to be the gold standard, how do you lay in potentially less sensitive tests or doing them less often? And I would just say the data is not clear yet. So these things are going to have to be tried and figure out what's the best method for an outbreak to mitigate an outbreak in that setting. I will say though, if you can bring down the overall number of infections in a community, you have a much higher likelihood, whatever program you put in place, of limiting infections in things like schools. So if your community is not going through a widespread outbreak, then you're less likely to have an outbreak in the schools that are available. So, you know, to me, a focus on bringing down community transmission while you figure out how to test for surveillance are things that need to go hand in hand. I had the saliva test collection come back positive after 13 days, got another test that came back negative, had an antibody test that was negative. Yeah, you know, we are seeing some discrepancies like this. I think that the challenge is the window of which when PCR is done, whether it's saliva or nasopharyngeal, seems to be pretty tight in some patients, meaning they only really have active virus, especially if the disease isn't very severe, for only a few days. And so in that setting, then potentially you could have a positive result and then not see that positive result show up. The other challenge with antibodies, and we're actually researching this at UCLA, if you have a mild enough infection or maybe an asymptomatic infection, remember that slide I showed where sort of everything had come off from the immune system and the macrophage picked it up and presented it. If the infection isn't severe enough, that may not happen. So then if that doesn't happen, you're not going to have IgG because you didn't have enough virus to be able to produce it. So these are the things that we're exploring right now. Next question. If we are planning on seeing family at holidays, they are flying, should we quarantine for 5 days, get tested, get results, and then see if we can get together indoors without masks? I don't know. So to me, when I'm looking through this, I really think about how immune compromised my family members are, right? I have an 81-year-old father, and while thankfully he's not immune compromised, he is 81. If I'm going to go see him, I'm going to be as safe as possible and probably quarantine 14 days. So I can ensure I'm virus-free before I'm around that person indoors without a mask. Outside of that, you know, it's very difficult to know. There isn't a test that you can run, let's say on day 3, that tells you you're negative, that will ensure that by day 8, you don't progress to symptoms. And so because that's difficult to do, it's hard for me to then suggest that you get together with anybody indoors without a mask, without a full 14-day quarantine, right? There's just been too many cases of at-risk family members dying because of family celebrations where unfortunately all precautions weren't taken. A person may not know, or they were lightly symptomatic, and then they exposed that person, and families have been devastated in that way. So, you know, I'm not suggesting not have holidays, but I'm just suggesting be as safe as possible. If you can, have them outdoors so you're not having sort of an indoor concentration. Yes, as uncomfortable as masks are, at least you're with your loved ones. Wear masks amongst the group that you're not potting, or go through the full 14-day quarantine. The next one, can airports benefit from implementation of rapid testing, weeding out travelers with high load of COVID? Yes, you know, I think that they could benefit from that. You know, I've looked into sort of, I know Hawaiian Airlines and some other places are attempting to do this. It's not going to get everybody though, and it's not going to ensure that everybody doesn't have COVID, but maybe it's better than nothing. You know, I think it's hard to know. And then can they afford to do those tests, and can they find those tests, I think is another question. It says, the next one, I'm confused by the chart that shows less than 5 days. How does that fit with a possible incubation time of 14 days? Yeah, that chart's cut off. So the average amount of time is actually 5 days from exposure to symptom onset, but it can actually be 14 days. So that chart is not representative of all possible incubation periods. It's just, they cut it down to the one that was the average. So that's why that 5 days is there. Does UCLA test all samples from the UCLA Medical Center? The answer is yes. UCLA tests all samples from the UCLA Medical Center. The next question, do you notify the Department of Public Health if the test is positive? Absolutely. We notify the Department of Public Health for a lot of the testing that we do in our laboratory. And to let you know, we actually do it by direct interface. So as soon as our result goes into our electronic medical record, it sends it directly to the state public health department, who then communicates that to the LA County Public Health Department. And that's true of all testing that we do, STD testing, COVID-19, you know, anything that is disease reportable comes across that way. We are at 1 o'clock. I want to thank you all for your time. You know, this has been sort of really great. I'm glad that I've been able to communicate this to you. Again, a shout out to my laboratory. A quick shout out to Dr. D'Artagnan Scorza, who's the president of the UCLA Alumni Group. He is a really close friend and colleague. And if there are other questions that you have, I know that there are a lot of you. I'm more than happy to communicate. Part of what I do as a professor is communication with the public. And so I can be reached at ogarner, O-G-A-R-N-E-R, at mednet, mednet.ucla.edu for follow-up questions. I hope you enjoyed the talk, and thank you all for your time.